Functions. So the basal ganglia, big picture, here's what it does. Provides a trigger for the outflow of preparatory movement from the supplementary motor area. So when you go to move, most voluntary movements, so we're talking primarily voluntary movement here, you're choosing to do it, the signal originates most of the time in one of those premotor or supplementary motor areas, those motor planning areas. That signal goes down into the basal ganglia circuitry, through the basal ganglia circuitry, back up to some of those motor planning areas to then release the signal to go tell the cortical spinal tract in the primary motor area to send the actual signal to the individual muscles and the anterior horn cells in your spinal cord. Okay? So you don't think of something and it goes directly from the primary motor area down to the muscle. Any voluntary movement, okay? So reflexive movement is a little different. Reflexive movement is happening because of reflexes and doesn't require that voluntary control. This is more that voluntary control, especially it's really important for things that we have done that are stereotypical in nature, things we've learned over time. And most of the things we do, most of the movements we make are combinations of movements or strategies or skills that we've done over and over again. So a lot of what we do is stored in those premotor areas. You release it, you decide you want to do it, it goes through the basal ganglia, back up to those premotor areas, and then that's where it triggers the supplementary motor area and sometimes the premotor area to release the signal to go to the primary motor area to tell the muscles what to do. Okay? It also helps to switch between behavioral sequences. So like one behavioral sequence, if I do a sit to stand, that's a pre-programmed behavioral sequence. The next pre-programmed sequence is to, like, if I want to go then walk, I got to start the walking process. So, and then if I want to sit down or stop, that's another behavioral sequence. So the basal ganglia is very important in switching between those behavioral sequences, is kind of make sure that does that appropriate with the right amount of speed, efficiency, and so forth, okay, especially during those automatic movements. It's involved in automation of movement, so the basal ganglia is very important for motor learning. If you don't have a good functioning basal ganglia, it's harder to learn motor skills. And so if a patient has a stroke in the basal ganglia or has Parkinson's, they have a little harder time. It doesn't mean you can't learn new motor skills, it's just harder and slower. They do help to regulate muscle tone and force to a point. You know, they do influence it, but they're not, you know, it's not like you have a problem in your basal ganglia and you have profound changes in muscle tone and force, but they help to modulate tone and force so that it's appropriate for the task, that when you finally send that signal to those muscles, there's a better chance it's going to be appropriate for the task because you've done it before. You know that this thing, when you grab this bottle, you apply a certain amount of force to it and so forth, and those are stored in the supplementary premotor areas, but you need the basal ganglia to help release that appropriately and efficiently. They also help to scale movement intensity and amplitude, okay? So, you know, how big the movement, the amplitude of the movement. So that's why when you see people who have problems with basal ganglia disorders, they make too small of movements or too big of movements. You know, with chorea, they're making too big of movements. There's too much. With Parkinson's, they would make too little movement. That's a hypokinetic disorder versus a hyperkinetic disorder. So depending on where the lesion is, the problem with your basal ganglia, you can either have too much movement, hyperkinetic disorders, or you can have too little movement, hypokinetic disorders. Okay? This all works with your cerebellum too. And so the cerebellum and the basal ganglia working together in combination with your reflexes all influence how your motor output looks. So these are all working together at the same time, overlapping each other, sometimes in somewhat of functional roles, but that's how you shape your total motor output, is through the combination of voluntary movement that's mediated through basal ganglia circuitry, through reflex movement that's mediated through spinal cord reflexes and so forth, brainstem centers that, you know, mediate some of those reflex types of movements, and then also sensory input coming into your system, that a lot of that goes up to the cerebellum to give you feedback about what's actually happening with your movements so you can make error correction. So all that together is what shapes your motor output. We've talked about the functional anatomy of the basal ganglia. It's got 5 fundamental components: the caudate, which has a head, body, and tail; the putamen; the globus pallidus, which has an external and internal segment; the subthalamic nucleus; and then the substantia nigra, which has a pars compacta and a pars reticularis. It's got two parts to it, a compacted part and a reticularis. So pars compacta and reticularis. And substantia nigra means black substance. And it's got that darkened, because dopamine has the melanin in dopamine makes it look dark. That neurotransmitter has a dark look to it. The functional divisions of the basal ganglia. There's the striatum. So the caudate and putamen tend to work together. That's kind of why they're functionally associated as the striatum, sometimes also referred to as the neostriatum. The corpus striatum is the caudate, putamen, and globus pallidus all together. The pallidum is just meaning the globus pallidus. Sometimes it's called the paleostriatum, kind of more primitive than the neostriatum and phylogenetically and so forth. And then the lenticular nucleus is just the putamen and globus pallidus together. So those are the functional divisions you should be aware of. And that kind of goes back to that little chart picture I showed you. Shows the groupings of those and so forth. The only thing that chart didn't show, it didn't talk about kind of the paleostriatum and neostriatum or the pallidum. So, loops. The basal ganglia has these loops. And the only loop we're going to talk about is the motor loop. So when we go to do a motor act, a voluntary motor act, it goes through that loop, back up to the cortex, and releases the motor output. Okay? You actually have these same loops for vision. When you decide you want to voluntarily move your eyes and so forth, there's an oculomotor loop that goes through. Same thing for our limbs, and we're going to be talking mainly about the limbs and trunk and so forth movement. There's a goal-directed behavior. So when you decide to actually do something, part of that is motor, but part of that is just the cognitive aspect of deciding something and then knowing the steps. Like if there's steps involved with a cognitive thing, there's a cognitive executive loop in the basal ganglia. So the basal ganglia doesn't just help facilitate and release motor output, it actually helps facilitate cognitive, goal-directed, systematic thought processes where you got to go from. So people with basal ganglia disorders and Parkinson's often have some difficulty with some of that sequencing of thought and have some mild cognitive deficits, sometimes pretty major cognitive deficits because of some of that involvement. It's also involved with social behavior, and there's an emotional limbic loop. There's actually a limbic loop with the basal ganglia. So the basal ganglia, these are all these parallel loops that are communications going on between your cortex, the basal ganglia, and so forth. It just helps to normalize and helps modulate overall output and input. Okay? So all we're going to talk about is the motor circuit, okay, which is known as the cortico-striato-thalamo-cortical loop. Makes sense, right? Starts in the cortex, goes into the striatum, which is the putamen and the caudate, which is part of the basal ganglia. So the striatum is kind of your basal ganglia part. That goes back to the thalamus, then back up to the cortex. So cortico, striato, thalamo, cortico. It's telling you that that's the loop because you're starting the cortex, going back to the cortex. Okay. I'm going to show you, so you don't need to know, this picture is not going to be anywhere on a test or anything like that. I just want you to appreciate the connections here in a anatomically correct kind of fashion here. So I'm going to highlight some structures here as we go through this. So what we're looking at here, just so you know what you're looking at, is, so this is a hemisphere, right? And this is, the other hemisphere would be over here. So this is your cerebral hemispheres, okay? This is your thalamus right here. You have a thalamus on each side of that. This is the caudate up here. This is the body of the caudate. We're looking at a frontal section right through the brain here. This is your lenticular nucleus right here, which is your putamen out here, and then we have our globus pallidus, externus, and internus segments here, okay? Sitting just down here is the subthalamic nucleus. This region in here would be your hypothalamus right in here. And then just a little bit lower, this is your substantia nigra, which is sitting in your midbrain down here. And you have a substantia nigra on both sides. Just behind that is the red nucleus. But that's the midbrain structure there, okay? So let's just point out some of the circuitry in here, and then we'll get to a more simplified version of the circuitry to kind of go through the actual positive and negative connections here. So the The caudate and putamen are what are referred to as the input nuclei. That's how the information or the signals get into the basal ganglia circuitry. So I'm going to show you those connections. So here's showing the cortex going into the caudate. Here's a couple neurons going into the putamen from the cortex. So this is just a cortical region, which could be the premotor or supplementary motor areas, sending axons down into the caudate putamen. That's how you send signals to get into the cortical striatal cortical loop. Okay? So that's that part of it. The globus pallidus externus, subthalamic nucleus, and substantia nigra compacta. So let's circle those. Here's the substantia nigra compacta. That's that one part of the subthalamic nucleus, and the globus pallidus externus. These are kind of called the processing nuclei. This is where there's connections between those nuclei depending on where those signals go and in what order, and whether they're excitatory or inhibitory will influence the output of the output nuclei of the basal ganglia. So those are considered the processing nuclei. The output nuclei are the globus pallidus internus and the substantia nigra reticularis. What we mean by output, that's how it gets out of the basal ganglia to go to the thalamus. So they're the only ones that communicate with the thalamus or the brainstem. Okay, those are the only ones that's how you get out of the basal ganglia structures. So the globus pallidus internus right here, and the subthalamic nucleus, the reticularis part. And you can see here's a axon going to the thalamus. So that's how you get out of the circuitry. Then here's an axon also down in the reticularis going up to the thalamus. And then there's another one going down to, there's a couple brainstem structures that it goes to influence some postural and girdle muscles and some basic walking motion too, the basal ganglia. That's how you, though, get out of that circuitry. Okay, those are the two output nuclei. Then you have the thalamus. The thalamus is here, and there's several regions of the thalamus that receive input from those nuclei. The ventral anterior part of the thalamus and the ventral lateral part of the thalamus. And then from the thalamus, that information goes up to the cortex, which they don't show on here. They don't show that final loop and show that information going from the thalamus back up to the cortex up here. Okay. So that is the general loop, which is basically like this, okay, through that. And then the information is processed in the middle here, and we're going to show you how that all happens here in a second with a little more simplistic picture, but I just wanted you to see the anatomical arrangement. This all happens, this connections and the communication between these different areas is using neurotransmitters. These axons are communicated, neurons are communicating with each other. It can either be inhibitory, and if it's an inhibitory connection, it's going to use GABA, which we know is the primary inhibitory transmitter of the central nervous system. If it's excitatory connection, it's going to use glutamate, which is the primary excitatory neurotransmitter in the nervous system. There's two other ones that are important to know. Dopamine is involved with this circuit. The interesting thing about dopamine, it can be excitatory or inhibitory depending on the type of receptor it falls in within the basal ganglia. Okay? It is excitatory to the direct pathway, which we'll show you in a moment, when it's bound to D1 receptors. But it's inhibitory to the indirect pathway when it binds to D2 receptors. The net effect is excitation of the motor thalamus, which goes back up to the motor cortex. So when you have the right amount of dopamine being, squirted into the basal ganglia circuitry, it keeps the direct pathway more active and it inhibits the indirect pathway. The direct pathway increases activity of the motor thalamus. The indirect pathway inhibits it. So you're exciting the excitatory pathway and you're inhibiting the inhibitory pathway. And so the net effect is you get more motor output. Okay? Now, there's also acetylcholine in the circuitry. Acetylcholine also can act as either inhibitory or excitatory depending on the receptors it binds to. Acetylcholine has the exact opposite effect of dopamine. So it inhibits the direct pathway and facilitates the indirect pathway. Everything we're going to talk about today, when we talk about cerebellum, basal ganglia, it's all a matter of pluses and minuses. It's all a matter of gradations of those. It's all a matter of adding up all the pluses and minuses, and that's how you shape the nervous system. And it's just, sometimes it's more complicated, maybe than it even needs to be or seems like it should be, but ultimately it's all about ramping things up or ramping things down. And there's always these balances, checks and balances. There's systems to increase nervous system activity, there's systems that decrease it. And they're always competing for balance, and they're always trying to modulate based on the task or the need that you're doing from a motor standpoint to get the right amount of output. Not too much, not too little. We're all about trying to do, all of us want to do the minimum work we need to get the task done, and our bodies are pretty good at trying to do that. So right now, just those are the neurotransmitters. And we start talking about some of the medications and how they affect the basal ganglia. And now if you're in your pharmacology class, this will help you understand some of this. I love simple. If you know this little setup right here, well, this is probably all you need for the exam, is to kind of understand the relationships here, okay, for the most part. But then we'll show you a little more detail, but this gives you kind of the picture here. So this is taking away all the anatomical relationships and all the complication there. This is straight up line diagram. Here's what's happening, okay? These are the two loops, the direct and indirect pathways of activity through the basal ganglia. These two loops balance each other out. They're both firing, they're both active in a sense at the same time. It's just that when you want more motor output and more forceful motor amplitude with larger amplitude, your direct pathway is going to get more active and your indirect pathway is going to get more inhibited. When you want less motor output, the indirect pathway will be more prominent and the direct pathway will downregulate a little bit, okay? In a normal resting state, we want a certain amount of balance between these two. We don't want to sit there and be doing this. We don't want our direct pathway too active, like in Huntington's chorea. We want to be able to sit quietly if we want to. But I want to be ready, if I need to get out of that chair pretty quickly. So there's a certain amount of activity or excitation you want of the direct pathway and a certain amount of inhibition typically of the indirect pathway that maintains kind of this normal resting state that keeps you ready for most activities, okay? So that's this balance between excitation, the direct pathway, you know, is excitatory to the motor, back to the motor cortex and the motor part of the thalamus, where the indirect pathway is inhibitory. So you want this balance. Typically, it's shifted towards the direct pathway because you're ready now to move. You're ready. Most of us are ready to move, but we don't want so much activity in that direct pathway we start having involuntary movements. We want these movements to be voluntary. So there's a little bit of a bias towards the direct pathway, but not too much bias, okay? So let's just show you these pathways that talk about how dopamine influences these pathways at any given moment. So first of all, these solid lines are positive, are excitatory connections, which are glutamate, okay? These little checkered lines there are inhibitory connections. Those are GABA. So let's just follow this out. The cortex, so the striatum is an inhibitory structure. The globus pallidus internus and substantia nigra reticularis combined are inhibitory in their influence. The thalamus, this is positive, this is excitatory back to the motor cortex. So if you want to look at this from a purely mathematical standpoint, you've got two positives, right, in this, and two negatives. What do two negatives do? They cancel each other out. They become a positive. Because if you inhibit an inhibitory structure, you make it more positive. If you inhibit the inhibitory ability of another structure, now you reduce its ability to inhibit. It actually makes it more positive. So the cortex, what the cortex does when you send this signal through the direct pathway, it increases the ability, it excites or increases the ability of the striatum to inhibit the inhibitory influence of this, which ultimately makes the thalamus have more excitation. So you're inhibiting an inhibitory structure, and this is making this do its best. This is actually allowing the striatum to do a better job of inhibiting an inhibitory structure. So sometimes it's easier to just think about two negatives make a positive, right? In math and also with connections between structures like this. They cancel each other out. So these two guys make so now we see positive, it's a positive feedback loop right here. And so these signals being sent through the direct pathway are excitatory back to the motor thalamus, okay, when you send signals through the direct pathway or when the direct pathway is more active. Now let's take the indirect pathway. And this is all happening at the same time. You have the direct and indirect pathways are all working, but depending on the amount of dopamine in the system, one is working more than the other. And we'll show you that in a second here. But let's just talk about the indirect pathway now. The indirect pathway, we have a positive. It's indirect because it actually has to go through the globus pallidus, externus, and subthalamic nucleus now, where this one went straight to it went straight through to here. This one has a couple extra steps. That's why it's indirect. It's got a couple extra connections. This is a negative. This is a negative. This is a positive. This is a negative. And this is a positive. We have three negatives in here, right? When you have three negatives, negative wins, right? These two negatives cancel each other out, but you still have a negative here in the system. And so that negative is going to now ultimately be inhibitory to that motor thalamus, which is going to make this motor thalamus less excitatory. So when you add up all the positives and negatives, there's more negatives in the indirect loop. And they're left over with actually a decrease in output from the motor thalamus. So if you can walk it, I'm not going to walk through every step, but you can walk it through in your head, and as you think about it logically, you'll see why that occurs, why these, when you just add up all the positives and negatives, it just makes sense that the indirect loop has more negatives in it, and the ultimate output, when you add these connections up, is going to end up increasing the inhibitory influence of the output nuclei over the motor thalamus, which then decreases its positive effects, downregulates the motor thalamus, okay? So what happens is, in order for these to be functioning properly, we got to add dopamine to the mix here. We haven't even talked about dopamine yet, right? So you have this substantia nigra, we'll just substantia nigra right here, that has axons that project to the striatum. To the direct and indirect loops. Dopamine here, when it falls on D1 receptors in the striatum, it increases the activity of the striatum. It makes the striatum do a better job of inhibiting the inhibitory influence over the motor thalamus here to make it more positive. So this is increasing the activity, essentially the net effect of D1 being done, of dopamine falling on D1 receptors in the striatum. It increases the activity of the direct pathway, acts as a positive influencer over this direct pathway. And when it falls in the striatum, this is all at the same place. This is all happening in the same place. It also falls on D2 receptors at the same time, okay? When it falls on D2 receptors, it inhibits the indirect pathway. So the more dopamine in your basal ganglia circuitry, the more motor output. Because with the more dopamine, it's falling both on D1 and D2 receptors. So the more dopamine you're squirting into that, the more the direct pathway has more influence over what's happening. There's more excitation. The indirect pathway is being inhibited. You have less inhibition of the motor thalamus. So the net effect is that the direct pathway has a bigger influence, and it's excitatory. So you get more motor output. As you get dopamine and remove dopamine from that circuitry, now all of a sudden you start losing some of that balance. No longer are you getting as much excitation of the direct pathway or inhibition of the indirect pathway overall. And so when you start taking dopamine out of the equation, overall the amount of motor output goes down because now the direct pathway is not as excited, the indirect pathway is not as inhibited by the dopamine. This is inhibitory. And so the net effect is you lose the normal balance. And now you have too little movement because this guy gets to do too much of his inhibitory influence. This guy doesn't get enough to do, is not getting enough to excitate the thalamus and the motor system. And so that's when you have classic Parkinson's disease. When you have destruction of the cells in the substantia nigra, they die off, and so you're not squirting enough dopamine constantly into the basal ganglia circuitry to keep it primed to the right level, okay? It's kind of like, I don't know, I think of car examples, but a lot of people don't get that, but like a carburetor, we don't have carburetor, fuel injector, you have a certain amount of fuel that gets squirted into your carburetor, and you have these jets, and you have these things that determine how much fuel gets into the cylinders to fire, how strongly. This is kind of like your fuel injector carburetor system in your car that influences ultimately how much fuel is going to get into the motor system to drive your motor output, okay? And the substantia nigra is one of the factors that influences that.
If you have atrophy of this substantia nigra, you would have a decreased motor output, right?
Right.
So why would the signs of Parkinson's be increased tremors and
They don't know exactly. The tremor part of it, the resting tremor, which is too much movement, it's partly because of the acetylcholine in the circuitry. That there's some other circuitry that we don't want to get into that is different from, that's a different part of the basal ganglia circuitry that leads to the resting tremor. But that's involuntary. We're talking, this is voluntary movement. So the tremor is an involuntary resting tremor, which is too much movement, but you only see it at rest. But when you ask somebody with Parkinson's to do voluntary movement, which we're talking about here, it's slow movement. They can't move as fast. The amplitude is decreased. They can't produce quite as much force. They're not truly weak, but they're maybe a little weak because of this. There's different circuitry in your brain and your brainstem when you don't have the normal voluntary balance of the basal ganglia that you might get this resting tremor, okay? But that's a great question. That's kind of the unique thing about that. That's the one thing that's different. There are people, it's interesting, Parkinson's is a unique disease. Even though it's called idiopathic Parkinson's disease, the presentation can be different for people. There is what's called a tremor predominant Parkinson's disease where they have a lot of tremor, but they don't have a lot of slowness of movement or they don't have a lot of postural balance problems. Those are the ones that actually respond best to some of the medications and also the deep brain stimulation. Like when they go in and they actually stimulate the subthalamic nucleus or the globus pallidus to try to normalize the circuitry. And they get these dramatic, you see them sitting there flopping around, they turn on the stimulator and it's like gone. And it's like, wow, miracle. And they look like they're doing great. And they usually do really pretty well. But then there's a subtype I see more of is the people that have a postural deficit predominant, gait and posture predominant Parkinson's, where they're really stiff in the trunk and their walking is really bad and their balance is really bad and they're falling all the time. They respond less favorably to the deep brain stimulation, to the medications. The medications often make them move a little faster, their limbs and their tremor go down, but doesn't help the gait and freezing or the postural control. So they really still need lots of therapy for that. So it just doesn't work as well for that. And they're trying to do things to fine-tune it, to get better with these deep dreams to affect those people. So this is a picture we're going to use in the next few pictures to show what's happening here. So this is showing you, this is a right and left cortex. Okay, so this is, if you look up here, this is the right, this is the left here. Okay, and this is showing you more of an anatomically positioned, the basal ganglia nuclei and the connections between them. So here is your cortex, and this might be your premotor area. You send the signal down to they just call this the striatum. That oval there is the caudate putamen together, okay? Then the direct loop, you go right here to the globus pallidus internus. They don't even have the subthalamic nucleus in here. Don't worry about that. But then it goes from there, it goes to the motor part of the thalamus, the VA and VL, and then back up to a motor cortex, to, again, probably a supplementary or premotor area that then releases the signal to go down the cortical spinal tract. It crosses over at the decussation of the pyramids and then goes down the lower motor neuron and the muscles. So this is the loop through here, okay? And that's showing you those positive and negative connections between each of those. And so this is the direct pathway. This increases excitatory thalamic input to the cortex, turns up motor activity. Then here's the indirect pathway. So here they are showing you the subthalamic nucleus right there. And this is showing you that more indirect connections because you add a couple extra connections. And when you add up all those pluses and minuses, the net effect is turning down or decreasing excitatory thalamic input to the cortex. I have on the Isidore, under the learning resources and so forth, this is a great paper. There's a great chapter paper that has, this is where these diagrams are from. If you want to read a really good, it's much better than your book about reading about the basal ganglia. It's a great way to, it's a good, very clinical, and I think it's more clearly written. These pictures are from that, so you have access to a PDF file of that. So now we're going to add dopamine into the picture. So here's dopamine. This is the substantia nigra, the pars compacta part. So here's dopamine being squirted into the striatum, and now you see both, this is the direct and the indirect loops, but you see that dopamine in the striatum, it increases the activity of the direct loop and it inhibits the activity of the indirect loop, because all this is happening at the same time, okay? So when you have the right amount of dopamine being squirted from the substantia nigra into the striatum, you have the appropriate normal balance between the direct and indirect loops, with the direct loop being slightly more excited, the indirect loop being a little bit more inhibited, so that the net effect is you get the proper amount of excitation back to the motor thalamus and back to the cortex to allow normal movement, okay? And this is, D1 and D2 receptors. So this is falling on D1 receptors and this is falling on D2 receptors. Got it? Now, let's talk about acetylcholine real quick, because acetylcholine also plays a role in here. The acetylcholine are little interneurons. There's interneurons within your striatum that produce acetylcholine. They also have connections with the direct and indirect loops, but it's the opposite. And so acetylcholine inhibits the direct and excites the indirect loop. So it does the exact opposite. The combined effects of acetylcholine turn down motor activity. The combined effects of dopamine turn up motor activity. Acetylcholine, though, doesn't have quite as strong effect as dopamine. Dopamine wins in most cases, but acetylcholine does play a role. It's in the background, counteracting basically what dopamine does. So these are all just ways you can nuance and influence the output of this basal ganglia, okay? The reason I point this out, too, is because, well, that's all right, we'll get there. Let me pause, sorry. So now let's talk about the disorders, and then we'll show you what happens to the circuitry with each of these disorders, okay? So we have basically two major classes of basal ganglia disorders. We have what's called hypokinetic disorders and hyperkinetic disorders. So hypokinetic disorders are your classic Parkinson's disease. There's also things called secondary Parkinsonism. So these are things that have characteristics of classic Parkinson's disease, but they always have something a little different too, okay? So things like toxic, infectious, traumatic, types of things, those are caused by known entities. Idiopathic Parkinson's disease, we don't know why it's idiopathic. We don't know why it happens. But there are things that can cause, there's like carbon monoxide poisoning is classic. It actually selectively, when you have carbon monoxide poisoning, it likes to kill striatonigral axons and dopamine producing cells. And so people who have carbon monoxide poisoning end up sometimes with Parkinson's afterwards, if they live, from the exposure. You can have infections that can damage those dopamine producing cells. Traumatic, there's a, what do they call it, pugilistica, Parkinson's pugilistica, where, like, if you think about even Muhammad Ali, you know, when you're getting pounded and your head is getting pounded and you get this rotational torque, the place that happens is actually between your cerebral cortex and your midbrain, because you got this big cerebral cortex on your midbrain, and you get this shearing between your cerebral cortex and your midbrain. Goes, every time you get hit or pounded, and you start to shear some of the axons projecting from the substantia nigra up to the basal ganglia, and you can get Parkinson's-like symptoms from, like, boxing. You know, if you do long-term head trauma in boxing, that's due to the rotational, you know, stress between the cortex and the midbrain and the substantia nigra. Then there's these Parkinson's plus syndromes. Parkinson's plus, so they have a lot of the symptoms of Parkinson's plus. Plus they have, a lot of times they have cognitive, like bigger cognitive disorders. Like Lewy body disease has a lot of the symptoms of Parkinson's, but they also have very profound cognitive deficits eventually. Okay, Lewy body disease, this is what Robin, what's his name, that killed himself? Robin Williams was diagnosed with, and they feel that maybe that led to his, you know, killing himself, because he knew what he was up against, and you start having some of the cognitive deficits, you have the Parkinson's deficits, and you know it's just going to get worse. So there's a thing called progressive supranuclear palsy, PSP, which is where, in addition to damaging the substantia nigra and causing the Parkinson's symptoms, they get often damage and degeneration to other nuclei within the brainstem. And this one happens to also affect one of the nuclei for the oculomotor nerve, and they get this thing where they can't look down. Their eyes go up and they can't look down. It's kind of a unique feature of this disease. So these Parkinson's plus syndromes, they usually affect the substantia nigra, which gives you the slowness of movement, the Parkinson's, but they also then will randomly affect other nuclei around the brainstem. So they might cause progressive supranuclear palsy. What they usually die of is they have swallowing problems, and they aspirate and they get pneumonia because they get damage to some of the nuclei associated with swallowing. Multi-systems atrophy is another term that's used to describe another term where they've got Parkinson's symptoms, but also tends to damage some of the nuclei in the brainstem that are associated with controlling your autonomic function. So they'll have like really wild swings in blood pressure, heart rate. They often have really low blood pressure and heart rates and so forth. But they also tend to have some cognitive deficits that are out of proportion to typical Parkinson's disease. These Parkinson's plus syndromes, they don't respond to dopamine replacement therapy like idiopathic Parkinson's disease, and they don't respond to deep brain stimulation and so forth, because it's bigger than that. It's not just a problem with the basal ganglia circuitry, it's a problem with other multiple systems and nuclei. And so one of the ways, so sometimes you'll be seeing a patient, a newly diagnosed Parkinson's patient, and I've had this happen several times, and normally it's a pretty slow progression. We expect to see actually the patient get better, because if you work them hard enough, you can see some nice benefits, especially earlier on in the Parkinson's disease process. But then all of a sudden you notice over the next few months, they're getting worse, and they're not responding to your treatment, or their cognition seems to be changing more than I would expect, or they're having these blood pressure problems when they come in. I can't get their heart rate up, and they're having these wild fluctuations in blood pressure. That's when I'm like, this doesn't seem like normal Parkinson's disease. And at that point, if they haven't been started on dopamine replacement therapy with the Sinemet, the physician will often try it, and then you're the one who has to see, because you're seeing them every day, are they responding to it as you expect? Are they getting better? Because if they haven't tried it, they'll try it and do a test. And if they don't respond to it, that's when they're going, this is probably a Parkinson's plus syndrome. Then they start looking at the constellation of symptoms and try to classify them. There's not an MRI, there's not anything they can do to say that they're going to have this until they start to see the constellation of symptoms that makes them fit into one of these other categories. But you are often the one who will catch that, hey, this person's just not responding to therapy, they're not responding to their meds like you'd expect with a typical Parkinson's disease. We need to get them back to their doctor, get them diagnosed, because that's just going to change the planning. You know, this patient, their family's going to have to plan for more rapid deterioration, more care, those kind of things. So, they have hyperkinetic disorders, too much movement. Huntington's disease, dystonias, cerebral palsy, hemiballismus can have too much movement. Those are any damage to the basal ganglia circuitry that makes the direct loop too active, or makes the indirect loop, you know, not active enough. You can get too much movement. It's either one. You get too much excitation or not enough inhibition, you're going to get too much movement. Parkinson's disease, the idiopathic classical Parkinson's disease, is considered to have 4 cardinal signs. Rigidity, you're stiff, rigid, and that's both directions, move the limb either way. They have akinesia and bradykinesia. Akinesia is the lack of initiation of movement. So if I say, hey, get out of that chair now, there's a delay. That's the akinesia. The delay between when their signal says go, it goes to the basal ganglia, but the basal ganglia doesn't work quite as fast. The time it gets back up to release the signal, it's a little delayed. That's the akinesia. That's that delay, that lack of movement, inability to initiate movement. Then once they do move, it's slower than normal. That's the bradykinesia. Okay, so that's the slowness of movement. Once they are moving, it's often slower. They have a resting tremor. Most of them have some subtle resting tremor. Could be foot, could be leg. You know, usually starts more on one side because your substantia nigra doesn't degenerate exactly the same on both sides. All you're having both sides degenerate. Usually one reaches the threshold first. There's a threshold of you have plenty of redundancy in your nervous system. You have to lose 80% of your substantia nigra neurons, dopaminergic neurons, to start experiencing symptoms. So by the time you start getting symptoms, you already lost 80% of them. Okay, and so but only one side of your substantia nigra will hit that threshold before the other. So it usually starts on their left or their right, but then eventually both sides are involved. Okay, once the other side crosses over to that threshold. Then the other thing is postural instability. If you're stiff and rigid, and we'll talk about some connections with some brainstem nuclei, the basal ganglia, in addition to going to the motor thalamus, that has some projections down to a couple brainstem nuclei, part of your medial activating system, and it turns them on too much so that you get a little stiff and rigid, and so you're posturally unstable. You don't have the flexibility in your postural control because you're just stiff, and you can't make nice little movements to when somebody pushes you to adapt to those changes. So the pathophysiology of Parkinson's is loss of dopaminergic neurons in the substantia nigra, the pars compacta component, leads to decreased activity of the direct loop and too much activity of the indirect loop. Okay, you lose that balance because you're no longer getting enough dopamine in there to keep those the right level. There is a classification system we use to describe just real basic, simple classification systems to grade or stage your Parkinson's disease. Is called the modified Hone and Yar scale. So your patient comes in, you might see in their report from the doctor, Hone and Yar, H&Y 3 or an H&Y 2.5, and this is just, all this is what it means. So 1 is they have some unilateral involvement only. You just see one side of their body having like maybe a tremor, a little slowness of movement. 1.5, they have unilateral, but now you're noticing their trunk is getting stiff. You know, they're getting some axial involvement. They're having a little postural instability. At a 2, now they have at least some bilateral involvement, but not really profound impairments in balance. You know, they still have reasonable balance. They're not falling all the time. You could destabilize them. They have fairly normal balance reactions. Now 2.5 is mild bilateral disease. They are still able to recover on a pull test, which is where you pull on their shoulders and they're able to either catch themselves with a step or they're able to kind of just reorient themselves without taking a step. 3 is mild to moderate bilateral disease, some postural instability. So now you're seeing balance they're at a risk for falls and you're seeing balance impacted. They're still physically independent though. They can do everything on their own. 4 is severe disability, still able to walk or stand unassisted. And then 5 is wheelchair bound or bedridden. It's a pretty crude scale, but it gets you, at least it gives you a ballpark. It's used a lot in research to grade people, just so you know what kind of patients they use. Like a lot of the research will be using like, hey, a 2.0 is their average Hoehn and Yahr, which means they're very mildly involved. So when you're interpreting that research, you're saying, and you have a patient who's a level 4, you're like, I'm not sure that research applies to my patient because they were using Hoehn and Yahr 2 patients who maybe have better opportunity to make improvements. This is showing you, this is a cross-section through the midbrain of a normal substantia nigra right there. This is that crus cerebri right in front of it. There's the red nucleus right here and right here. There's the substantia nigra. And then this is somebody with Parkinson's. See how much lighter it is? There's very little darkness, dark colors in there. So they've got 80–90% loss of those dopaminergic neurons. There's no test for Parkinson's. There's no, you don't see that on MRI. Now, they may get to the point where you can see some of that stuff on MRI. You can a little bit on MRI, I guess you can now. But they just go by symptoms. You just go by the constellation of symptoms. All I want you to understand here is, here's the basal ganglia. Here's its influence on the motor thalamus. Because of the influence on the motor thalamus, you get the appropriate amount of excitation, that balance between the direct and indirect loops over voluntary muscles. But you also have to understand that the basal ganglia also has connections with the pedunculopontine nucleus. Pedunculopontine. It's kind of between the pons and the peduncle, in between the midbrain and pons. Don't worry too much about where that's located. But there's a specific nucleus called the pedunculopontine nucleus that influences reticulo and vestibulospinal tracts. Those are our medial activating system tracts, right? Those postural and gross movement activating paths. When everything's functioning normally, it influences the pedunculopontine nucleus to inhibit the excitatory influence of those tracts so that you have the appropriate amount of output over the postural and girdle muscles. Not too much, not too little, it's just the right amount. So you have the right amount of voluntary movement, you have the right amount of tone in your postural girdle muscles, that they provide the right stabilization, but they're not too stiff or rigid, okay? When you have Parkinson's disease, now you get too much inhibition of the motor thalamus, which reduces the amount of, you see these smaller red lines. Now you decrease the ability to use your voluntary muscles, but you've inhibited the pedunculopontine's inhibitory ability over the reticular and vestibulospinal tract. So these guys have too much excitation over the postural and girdle muscles. So not only do you limit these voluntary distal muscles from working very well, but you stiffen up the postural and girdle muscles, and they're overactive. That's where some of the rigidity comes from. The rigidity happens to be more proximal. They get just stiff and rigid because their postural girdle muscles are turned on too much, plus their voluntary muscles and distal muscles just move slower and less amplitude. So that the combination of those factors is what leads to that classic stiff and rigid looking posture with too little amplitude movement. Does that make sense? You don't have to know the intimate details of this, just know that the basal ganglia does influence brainstem centers, not just back to the cortex. In your 4th edition, they add something. They add another connection with an influence over stepping pattern generators. So like there's another area in your brainstem that tends to facilitate, once you get going with stepping, that maintains that stepping. It goes down to the spinal cord and tells the spinal cord to keep doing that little repetitive thing of stepping. You lose some of that influence. And so they get this short shuffling steps because they can't generate the stepping generators as easily to keep that flowing. Okay, so. All right. Let's just pause there and take a little short break.